We welcome our speaker, Dr. Praveen Kumar NS, for the topic Surmounting Obesity with Tirzepatide. We welcome you, sir.
Hello. Yeah, hi, Dr. Praveen. Hi. So, I always say that these are exciting times. You can understand that out of 8 hours of this session, almost 1 hour is to obesity. And we'll have this session dedicated to obesity per se, and we'll have first talk by Dr. Praveen, and second talk will again be related to the tirzepatide. This is surmounting obesity with tirzepatide. But just before he starts his talk, you'll be glad to know that now either we are having a lot of buzz about obesity. Even our Honorable Prime Minister also mentions obesity. And therefore, he has said that to have more of lifestyle modification and cut down on oils and all. But this is true. This is the true fact that we are having. And we have lot of drugs that have come up in past maybe 20, 30 years, but almost all have died. So this is one of the few drugs that I believe that have been approved by FDA and even DCGI, that is Indian Regulatory Authorities, for chronic weight management. There is hardly any drug for chronic weight management in non-diabetic patients. So this is one of the drugs that is approved for chronic weight management in non-diabetic patients, and definitely Dr. Praveen will highlight over that. So that gives us suggestion that we as the physicians now should classify obesity also as a disease. Other people used to say somebody healthy means somebody obese means healthy, but this is not so. We are having a lot of disease associated with obesity, and Dr. Praveen will definitely clarify all the thoughts, and followed by Dr. Srinath, who is here, who will tell you how to use tirzepatide. Your part. Thank you.
So good afternoon, everyone. At the outset, I would like to thank Lily and Dr. Ganesh sir for this opportunity. I will be discussing about the surmounting obesity with tirzepatide. This is my disclaimer. So today I will be addressing in the first slide regarding the mechanism of action of Mounjaro. In 1970, when they found that there was something called GIP, which improved the insulin secretion, they termed it as incretin. Incretin is any gut hormone that would amplify the insulin secretion after nutrient ingestion. With the first discovery of GIP, which was called glucose-dependent insulinotropic peptide, they found it was secreted from the K cells of the proximal duodenum, and then the discovery of GLP-1, which was from the distal ileum, which had its action similar to that of GIP. On the one, it increased the insulin secretion. Eventual studies showed that it also improved the reduction in the glucagon, thereby both of its action on the liver improved or reduced the hepatic gluconeogenesis or the output. And what it also showed, both these molecules put together had an impact on the gastric emptying, almost double the gastric emptying time. This actually was one of the strongest factor in the studies that was done for its beneficial effect on the diabetes, on its mechanism of action, where it significantly reduced the prandial. So on the one hand, it improved the fasting. On the other hand, it improved the prandial by delaying the gastric emptying. On the parallelly, what they found was these patients, apart from excellent glycemic control and phenomenal HbA1c reduction, they had significant weight loss. To understand what was the mechanism of action regarding this weight loss, there were three key mechanisms that were answered with this molecule put together. On the one, on the action on the hypothalamus, where it acts upon the appetite center to suppress, on the satiety center to increase the satiety. And second thing, it was actual action upon the mesocorticolimbic mechanism of action, where on the amygdala, where this hedonic response that happens. See, after a wonderful meal there, we will still love to go and have an ice cream at Pabbas, probably gut, but that comes from the cravings. So this cravings is one factor where these patients with obesity had an issue, and this craving or the reward thing was taken away from this combination of therapy. And third thing, it's also the gastric emptying that was reduced with this twin cretin, what we call twin cretin now, because of both incretins. And the third thing, it also showed this was largely or summatively mediated by the sensory afferents from the vagal of the intestines. So what another unique action the GIP-1 receptor had on adipocytes was it regulated the glucose uptake and modulated the lipid uptake and lipolysis by binding to human adipocyte and activating GIP receptor. So this also would also give the benefit of on the peripheral resistance that actually happens in diabetes in type 2. Now through this combined mechanism of action of GIP and GLP-1, Mounjaro lowered the body weight, resulted in greater fat mass loss than the lean mass that has been a concern. So this is the mechanism of action in chronic weight management with this molecule of Mounjaro. Coming to the next slide, where we are trying to discuss about the series of trials that were conducted. All of them are robust clinical trials of randomized control, which were double-blinded, very long studied with this from 1 to 5. And with this, studies were done with 5 milligram, 10 milligram, and 15 milligram, and patients with maximum tolerated doses. And the one, we just looked at the weight management. So anybody with weight of more than BMI of 30 and above, or with 27 and above with comorbid, one or more comorbid conditions were included in most of these trials. In the Surmount-1, it was compared to the placebo. Surmount-2, it was weight management, type 2 diabetes was studied. In Surmount-3, weight management after intensive lifestyle modification was looked at. And Surmount-4 would looked at the weight reduction maintenance. The question that would happen in most of our, when we're using a molecule for chronic weight management is once we stop it, what would happen to the weight again? Will that be rebounding to the baseline or will there be any residual benefits? So Surmount-4, that answered that question. And with the fifth one, we will be discussing that Surmount-5. Now coming to the Surmount-1 study, though it investigated Tirzepatide in 5 milligram, 10 milligram, 15 milligram versus the placebo in adults with overweight and obesity with complication excluding type 2 diabetes. It's a phase 3 multicenter randomized double-blind placebo-controlled study in 119 sites in 9 countries. Participants were 2,539, had co-primary endpoints of percentage change in weight from baseline at week 72, percentage of population with weight reduction of more than 5% at 72 weeks. Now, as you see, can you see on the screen that it was randomized in the ratio of 1:1:1:1, and the medicines were started at the smaller dose of 2.5 milligrams. After 4 weeks, it was escalated to 5 milligram, and it was maintained in one group. And in the second group, it was increased to up to 10 milligrams, subsequently with dose escalation of 2.5 milligrams every 4 weeks. And in the largest dose was used was 15 milligram. And now the weight loss was seen as early as 4 weeks, and the powerful weight reduction was seen with Tirzepatide by the end of 72 weeks. As you can see, even with a small dose of 5 milligrams, showed nearly 16% of average weight reduction from the baseline body weight, compared to the maximum dose of 15 milligrams of Tirzepatide, which showed 22.5% of body weight reduction at the end of 72 weeks. With 10 milligram, it showed 21.4% of body weight loss from the baseline. Now, the interesting thing about 5 milligram is majority of the patients with obesity achieved more than 10% with 5 milligram. As you can see, nearly 90% of them achieved with 5 milligram alone. 73% of them could achieve more than 10%, and 50% could achieve more than 15% of the body weight loss. Coming to the next slide, where it showed more than 50% of the participants crossed more than 20% weight loss barrier with Tirzepatide. With 15 milligram, 8 out of 10 patients would achieve more than 15% weight loss, and 2 out of 3 would achieve more than 20% weight loss with Tirzepatide of 15 milligram. Now, this was studied in that with patients with obesity on Tirzepatide experienced improved body composition. The changes in the body compositions were evaluated in the sub-study in Surmount-1 using the DEXA body composition, which is the gold standard currently. The treatment with Tirzepatide was accompanied by greater reduction in fat mass than in lean mass leading to improvement in the body composition compared to placebo after 72 weeks. Furthermore, this reduction in total mass was accompanied by reduction in the visceral fat. So these results suggested that most of the total weight loss was attributable to the reduction in the fat tissue, including the visceral fat. Now coming to the additional benefits, what it actually showed was, it showed the improvement in the systolic blood pressure to the tune of 7 to 8 millimeters of mercury reduction, with diastolic blood pressure improvement to the tune of 4.6 to 5.5 milligrams reduction, and reduction in the triglycerides by 24.3 to 31.4, and improved HDL and reduction in the LDL. So this put together, these are the cardiometabolic improvements that were observed with Mounjaro at 72 weeks. Now coming to this Tirzepatide maximal tolerated dose versus semaglutide maximum tolerated dose. As we understand, anti-obesity medication have come a long way. In the whole process, currently we have 6 molecules that are left. Currently in India, we have 4 molecules that are, actually 4 molecules are there, but 3 are actually being approved. One is Orlistat we have got, that's the oral molecule with a body weight reduction of about 3%. Injectable liraglutide could be used, but not approved in India, but with a dose of 3 milligrams, it would show weight loss about 5 and plus. But with injectable semaglutide, what is shown in 2021, which got its US FDA approval for weight loss, was 15.2% of weight loss from the baseline, which was phenomenal at that time compared to the bariatric surgery. And then came the semaglutide, which also showed, as we observed that in 2020, which was approved for the weight loss, it showed weight loss with maximum tolerated dose of 15 milligram to 22%. Now this Surmount-5 actually looked at these 2 molecules head to head. And this is the phase 3B multicenter randomized parallel arm open label active comparative control trial, which involved 750 participants, where these 2 molecules were observed gradually titrated every 4 weeks. Mounjaro and semaglutide were administered subcutaneously weekly as an adjunct to reduced calorie diet and increased physical activity. And with a primary endpoint of percentage change in the body weight from baseline to the week 72. And the observations that was found at the end of 72 weeks was that participants who are on Mounjaro with maximum tolerated dose experienced a mean percentage weight reduction of minus 21.6% when compared with semaglutide, which showed 15.4%. And 36.2% of participants taking Mounjaro demonstrated mean weight reduction of more than 25% at 72 weeks. And also another interesting finding, what it showed was regarding the waist circumference. Patient with Mounjaro had waist circumference reduction of 20 centimeter when compared to the semaglutide, which showed reduction in the waist circumference by 14.7 centimeter from the baseline. Now the question to answer, what happens if we discontinue Mounjaro? So to observe that, like the patients were made to, all the participants took the Mounjaro for the period of 36 weeks. Later, with the maximum tolerated dose, one arm of the patients continued with the maximum tolerated dose of 10 to 15 milligram, and the other one continued with the reduced calorie intake and the physical activity. What it showed at the end of from 36 to next, when continued for 88 weeks, was there was progressive improvement in the weight reduction in patients who continued to take Mounjaro. That was durable. On the other hand, like patients who discontinued and who were only on the lifestyle management showed persistent weight improvement still, but when compared from the baseline, there was nearly 11% reduction with gain of weight by nearly 9.5%. So in the end, like even after discontinuation of this molecule, the patient will continue to retain some of the weight loss what they have achieved. Coming to the adverse effects, once we have understood the efficacy of the molecule regarding the chronic weight management, what are the adverse effects that are being seen with this molecule? It was largely related with the gastrointestinal side effects like any other ingredient-based therapy. Mainly the commonest was the nausea, followed by diarrhea, constipation, dyspepsia, and vomiting. And this was similar across all the doses, although mild symptoms were noted with 5 milligram. And another thing that important to carry from this adverse effects, apart from the GI side effects, were about the hair loss, which was nearly seen in 5.1% with Mounjaro 5 milligram and similar with 10 and 15 milligram. And actually, the percentage of participants who discontinued therapy because of the adverse reaction were not that significant, which was nearly 4.3 and 7.1 with 10 and 6.2 with 15 milligram respectively. The discontinuation just because of the GI side effects were not very high, like it was 1.3% and 2.8%, 2.9 with 5, 10 and 15 milligram respectively. And these side effects with GI were seen in significant number, but most of them could tolerate, and gradually it improved, or they could be comfortable gradually. And these were usually seen on dose escalation and improved during the course of time. And coming to the Surmount-5, where it compared head-to-head with Mounjaro and semaglutide, the overall safety profile of Mounjaro was similar to previously reported Surmount trial, and it was comparable with respect to the adverse reaction who are taking both Sema and Mounjaro. And similarly, like the GI side effects were primarily occurred during the dose escalation, which improved gradually with the period of time. Coming to the treatment emergent adverse effects, as you can see, like it was seen in significantly 79% and 76% with Sema and Tirzepatide, but the discontinuation was in very few, especially with respect to GI side effects. Coming to Surmount-4, the same thing, like comparable side effects in whatever all this trial showed was nausea, diarrhea, constipation, and GI side effects. Some of the patients would certainly complain of alopecia, which is something we should be careful when we are offering this molecule to our patients. And to summarize, Tirzepatide significantly reduced body weight by an average of 16% with 5 milligram and 22.5% with 15 milligram. Tirzepatide with maximum tolerated dose demonstrated superior weight reduction when compared to the semaglutide of maximum tolerated dose of 21.6 versus 15.4%. Key cardiometabolic parameters were shown improvement with respect to blood pressure, waist circumference, triglycerides, and HDL. The most common adverse reactions were gastrointestinal in nature and were mostly mild to moderate. With this, I would conclude my presentation. Thank you.
So it is nicely summarized that in patients of obesity without diabetes, Tirzepatide can lead to 16 to 21% of weight loss.